The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. My name is Amy Russell, and I am the Member Services Director at IDOC. Thank you for joining us all tonight for the webinar by Dr. John Rumpakis. It is titled Coding for Special Ophthalmic Procedures. And this is number 5 in an 8-part series of webinars that Dr. Rumpakis is doing for IDOC. We will have another one coming up on August 16th. Please know that this webinar is recorded and it's available for everyone to view on the IDOC website, and it will be up for about 90 days. Dr. Rumpakis is one of the leading industry speakers on billing and coding, and he's also the founder of CodeSafe Plus and Just Ask John. Both of these are IDOC member benefits that you can look into. We appreciate Dr. Rumpakis' long-term support of IDOC and also appreciate his time here with us tonight. Dr. Rumpakis, I will hand it over to you now.
Great. Amy, thank you so much and welcome everybody. I hope everybody's summer has been going great and you've been enjoying it. Maybe I'd like to say the slower pace of summer, but I think we all would agree that just that doesn't seem to happen too much anymore. As Amy said, tonight's webinar is specifically on special ophthalmic procedures and how to establish medical necessity, all of those types of things that are an integral part of our practice. One of the things I want to make sure of that you know as well, you can ask questions by typing them into the question box over on the right-hand side in your little panel that popped up. From time to time as we go through, Amy will interrupt me and we'll make sure we answer as many of your questions as we possibly can during the course of tonight's program. So with that, we'll go ahead and get rolling right away. As you guys all know, I'm a consultant. I'm not in clinical practice. I really do a lot of work within the industry on various things. The companies that I currently have representation with and I do work for are listed here. As most of you know, I'm the Chief Medical Coding Editor for both Review of Optometry, Optometric Management. And while not officially the Medical Coding Editor in print, I do write frequently for Review of Cornea and Contact Lens, Ocular Surface News, and other publications as well. So as we go forward, a couple of other things we want to talk about. Since we're going to be talking about fees and we're going to be talking about policies and procedures, understand that everything is current as of today. I'm going to be giving you national average values for the CMS fees when we talk about a procedure. So please understand that your, reimbursement according to Medicare could be, plus or minus 6 or 7% depending on where you are around the country. Also remember that always be familiar with your own local policies, and we'll be talking about that specifically because remember the geography of the United States as it's disseminated by the different carriers that are out there. Things are broken up into geographic region, often as specific by your zip code. So please make sure you know your policies where you live and where you practice rather than relying upon what somebody else is doing. We're not going to be really getting into clinical coding cases, but please understand if you ask questions regarding clinical coding cases, my answers are going to be as specific as they can be with the information presented to me. So remember that just one variable in a clinical case history could be, could vary the coding of anything that I talk about. But we'll do our best as we go forward. So when we talk about special ophthalmic procedures, it's really important to understand that every single special ophthalmic procedure that we do has a specific definition, and that definition contains characteristics about the CPT code, such as laterality, global period, requirements for interpretation and report, diagnoses that are related to it, frequency of use, all of those sorts of things. And so it's important that you get your resource material and you have your rule books, right? So the rule books are really the CPT book, the ICD-10 book, and the HCPCS Level 2 book. Those are the 3 rule books you're going to buy. Your total investment, should you buy those 3 things, will be in the neighborhood of about $279 total. A very small price to pay for understanding how you can use the codes that represent the technology in your practices today. Also, as Amy had mentioned, we offer codesafeplus.com and justaskjohn.info as member benefits for IDOC. We will be using codesafeplus.com tonight as a demonstration tool. If anybody has questions about CodeSafe Plus, I will not be answering those on the webinar, but if you want to contact me afterwards, you're more than welcome to. My email address is on the top, john@prmi.com. That's my private email address. When you email me, just say, hey, John, I was listening to the IDOC webinar on special ophthalmic procedures, and here's my question, and here's where I practice. So that way, if I can answer the question, I can give it to you with geographic specificity. The two different websites for CodeSafe Plus and Just Ask John are listed below as well. We do have demo programs that are free of charge, so that way you can experience both of those programs. So, I always get this question, how do I code this? And it's probably the most frequent question that I get. So, this is a conversation regarding special ophthalmic procedures. And I had this with two doctors on a conference call. Now, they both called me, they both had questions, and this was kind of a subset of the overall conversation. Doctor number one, how much do you charge extra for dilation? My answer, dilation is included in the definitions of both the comprehensive ophthalmological exam, an intermediate exam, and the evaluation and management codes, so therefore you cannot charge extra for dilation. Doctor number two butts in and says, of course you can charge extra for a medical dilation. My answer, there is no such thing as a medical dilation. Doctor number one, of course there is, 92225. Which for everybody's benefit is extended ophthalmoscopy, a specific special ophthalmic procedure, okay? Also, you can have them return and charge the dilation as a cycloplegic refraction since all dilating drops have a cycloplegic action. Please understand there's also no such thing as a cycloplegic refraction, okay? I mean meaning a code for that. My answer back to them is 92225 is a separate and distinct procedure for extended evaluation for serious retinal conditions. It's not used to bill for dilation, okay, for which again is part of the medical office visit. It's a distinct and separate procedure for which dilation is a requirement to do. And charging for the refraction when you were doing something is no different than charging for a photo, so it's fraudulent. Doctor number two, hey, listen, we bill 92225 or 92226 in addition to every office visit where we have to dilate. We've been doing it for years and we've always gotten paid. Just, John, you're just being trying to give us more paranoia, trying to downplay medical billing. Go attend another seminar by somebody else if you want to learn how to do medical billing like real doctors do. My answer back to them, good luck with everything and have a nice day. So, the thing is this, is each and every code that we use has rules and regulations that surround it. Since you never send your medical record out of your office, and the only thing that you send out is a claim form that has the codes on it, when you have that claim form, you are implying that you know everything about that definition, and you are representing that your medical record will support the definition of using that particular code since you're getting paid extra for performing that code overall. So it's important that we understand the parameters in which we're working with. Now remember, Medicare also has some guidelines, and the OIG, or the Office of Inspector General, also has some specific things that they talk about that they identify as as worthless services. So on this slide, please understand that the bold and italic blueprint are my highlights, okay, because those are the things that are most pertinent to us on this page. So a worthless service is something that's not supported in peer-reviewed medical literature, something that is not medically necessary in a specific case or for a specific ICD-10 code, something that is furnished at a level, duration, dosage, or frequency not appropriate for a specific patient or a specific ICD-10 code, something that is furnished in a manner for patient or provider convenience. Something is a worthless service if it's a device not approved by the FDA. So these things are very important because when Medicare screens for these things, and understand with the implementation of the ICD-10 now nearly 2 years ago, remember they're able to flag things with increased specificity, and the computer screening programs that they do and how they can really flush out providers who have high utilization rates or who are using certain diagnosis codes with a greater frequency than literature would support get flagged for audits, okay? So remember, anytime we're doing things, let's make sure we're adhering to fundamental principles. So when we're performing our services, evidence-based medicine drives our clinical decision. Medical necessity should be driving our decision about what does this patient need, not necessarily what do I want to do with this patient, right? Meaning I just can't do something because I want to do it. I have to demonstrate need in the record. And remember, since we're fiduciaries for our patients, we have to always act in their best interest overall. So here's the definition of medical necessity. And you'll see here in just a moment why I'm reemphasizing this, even though we've covered this before in earlier webinars. Services or supplies that are proper and needed for the diagnosis or treatment of the patient's medical conditions and that are provided for the diagnosis and direct care and treatment of the patient's medical condition that meet the standards of good medical practice in the local area and are not mainly for the convenience of the patient or of the physician. Interesting, particularly, right, when we go back here and you see what is at the very bottom here, a worthless service is something that is provided for a patient or provider convenience. So keep that in mind as we're going forward. So what does a medical necessity really boil down to? When you're going to do a procedure, order a special ophthalmic procedure, order an OCT, a visual field, a fundus photograph, and corneal specular microscopy, whatever it may be, you have to demonstrate, right, that the service was absolutely necessary for you to do, not convenient, not to cover your rear end, but necessary from the patient's perspective in order for you to diagnose, follow a diagnosis, treat, or follow the treatment of the patient's condition. That's what's critically important, okay? So, we will have some examples of how you create that order and what that order needs to look like and how it needs to read. Please make sure you understand the fundamental principle is that the only thing that the carrier can use against you in an audit is your medical record. The only thing that you can use in your own defense is your medical record. And the only thing that you have 100% sole control over is the medical record. So when people contact me to help them in their audit defense, and I look at their medical records, and their medical records don't support their actions, they want to know whose fault it is. And I have to tell them, look in the mirror, because you had the ability to prevent this from happening, but you didn't do it because either you were complacent, lazy, maybe the patient didn't need it, you couldn't justify it, whatever it may be. If the documentation and the necessity isn't in the record, you are not on safe ground. Now remember, when you submit your CMS 1500 or the electronic version, the 437, here's essentially what you're saying, right? In submitting this claim for payment, and you can substitute federal funds for third-party funds, I'm just using Medicare as an example here, I certify that the information on this claim form is true, accurate, and complete. I have familiarized myself with all laws, regulations, and instructions from the insurance contractor. I have provided or can provide sufficient information required to allow the insurance carrier to make an informed eligibility and payment decision. Just that statement alone says, come in and audit me anytime you want. This claim complies with all insurance program instructions. Okay? Now that is in the fine print. When you sign it, you're also agreeing to be prosecuted, okay? My signature below, electronic or actual, is to certify that the foregoing information is true and accurate. I understand that if I've misrepresented something through a false claim or a statement or concealment of material fact, I may be prosecuted under applicable federal and Stark laws. So when we talk about audits here in just a moment, you'll understand why the top reasons for audit are failure to establish medical necessity. And I can tell you that Medicare is kicking some rear end when they're doing things. I'm just going to show you some figures here. 11.6% return on investment, right? So I want you to look at this little paragraph right here in the middle. It says for each federal dollar spent, they get $11.60 back from physicians and hospitals for failing audits. So this is a very successful program for the federal government, and it's a very successful endeavor by all other third-party carriers as well. So it's important to understand they don't mind spending money on this because they understand that they get it and everything else back. So what triggers an audit when it comes to special ophthalmic procedures? Using codes that are under review, not reviewing your submitted claims, abusing code, inconsistent billing patterns, maximizing revenue by performing tests without sufficient documentation, cloning your documentation and not understanding how to use modifiers appropriately. Okay? The top 3 issues for audit: lack of medical necessity, improper coding, right? And then improper use of modifiers. So what we're really going to focus on tonight is 1B here, right? How to establish medical necessity for special ophthalmic procedures and why that's such a big issue. Okay? So as this...
Dr. Rump,
yes.
I'd like to interrupt you for 1 second. We have a question in regards to tests. It's, can we order a test and perform the test the same day, i.e. a fundus photo, and where do we record the order?
I will be getting to that in just about 2 slides, so that's an excellent question. I promise I'll answer it thoroughly, okay?
Perfect.
Great. So the point that this cartoon makes is a simple one. Your patient's medical insurance is not the same thing as your malpractice insurance. You cannot order tests to document normal. You cannot order tests to establish a normal baseline just to demonstrate that it's normal, okay? Normal is a condition that can be recorded through your physical exam, not through additional testing or ordering of additional tests. So please make sure that you understand that fundamental principle, okay? Because it's really, really important. Now, the CMS 1500 form, right? Standard document, everybody's aware of it. Here's what I want us to concentrate on. So if this looks familiar to everybody, I want us to pay attention to box number 17, 17B, okay? In that area there. So I want you to understand that you have to identify yourself as a proper role here. So the qualifier DN, DK, or DQ, whether the patient was referred in by somebody else because they didn't have a piece of equipment in their office, you had ordered it and performed it by using DK, or you were just supervising a test. Now, typically we don't do that in an optometric practice. Most likely it's going to be DK as the number 1, DN as the second. So what are we going to pay attention to? We're going to pay attention to these 3 boxes here. So in this little area here is where you would put your indicator, DK or DN, right? You would put your name right here, and you would put your NPI right here. In this area, you would put a 0 to indicate that you're using ICD-10 codes. All right. Now, I hope that your software is doing this already by itself, but if these are blank and you're ordering special ophthalmic procedures, you will not get paid. You will get a error code on your claim form CO16, which basically says that the carrier is requiring additional information for appropriate adjudication of the claim. So let's talk about special ophthalmic services. First and foremost, you have to understand that these are never part of an office visit. So if you have an insurance carrier that's trying to get you to bundle these services into an office visit, you have to understand that you have documentation on your side that you can push back against that to the carrier and say, hey, not so fast. The CPT clearly tells me that these are special tests, right, that are beyond the services included under the general ophthalmological services or which special treatment is given, and that these services can be reported in addition to either the 92,000 or the 99,000 codes. So now to kind of get to the question that you just brought up to me, Amy, when can I do a special ophthalmic test? You can do them any time you want. You can do them on the same date of service as an office visit, whether the office visit is through a managed vision care plan or it's through a medical insurance carrier. There are no limitations on performing any special ophthalmic test and an office visit on the same day. All right. Now remember, you may have a different business issue with it, not a coding issue with it, because you may have one copay that you have to pay to the managed vision care company, and you may have a copay or a deductible that you have to collect for the medical insurance carrier to which you're billing the special ophthalmic procedure. So you may have to collect the procedure in full because they have a high deductible, whatever. And all of those things have to be disclosed to patients ahead of time. But as far as coding rules on doing those tests on the same day, no problem at all with any office visit. Can you do the same test? Can you do the tests in the office when the doctor's not even there? Absolutely. Okay? Not a single ophthalmic test has supervision rules that require the physician to be in the office. They do require the doctor to be accessible by telephone, but not directly in the office or in the examination lane itself. Do you have to collect 2 copays? Sometimes. And can you order tests way ahead of time? So my answer to the last question is sometimes. For example, images such as a photographic image, such as a fundus photograph or a anterior segment photograph, cannot be ordered way in advance, like 3 months, 6 months in advance. The reason that they cannot is because you have to examine the patient first on that particular day and demonstrate need before you can actually order and perform the test. Tests like visual fields or an OCT that can see things that you cannot see by direct examination can be ordered in advance. Now, every special ophthalmic procedure has 2 components to it, a technical component and a professional component. When you are actually doing the entire procedure in your office, you never break it apart. You only put a modifier on it for the technical component or the professional component if you're only performing one of those components. So if a practitioner referred a patient to you just to perform the scan, but you were not doing the professional interpretation, then you would only bill for the technical component, and they would only bill for the professional component. But if you're doing the test in your office, you never use modifiers like this at all. You always bill just the whole code itself. Okay? Now, some people always ask, well, John, can I bill for my staff time that it takes to do the test? I'd like you to use that staff office visit code 99211. You cannot do that. Why? Because when you're performing the code in its entirety, or you are performing just the technical component, please understand that the technical component is the equipment and the technician who is performing the test. Okay? So that's already covered in the code itself. Most special ophthalmic procedure tests are subject to the Multiple Procedure Payment Reduction Act of 2013. So this went into effect 4 years ago. This year, though, we did have some positive changes when we're doing various tests on the same day. You can see here that the reduction that is being taken is about 6% less than it has been in previous years. And don't forget that with the federal government, you're also getting an additional 2% taken away from you because of the sequester that happened 5 years ago that Congress has never yet funded or satisfied. So when we are talking about procedures, remember that carriers will often establish medical necessity and they'll establish rules. So what I'm going to do is I'm going to go into CodeSafe Plus and we're going to go ahead and take a look at what a draft policy looks like so you can see that. I'm going to just go ahead and log right in. And as you know, CodeSafe Plus, member benefit for IDOC, is a real-time zip code specific program that provides you with every rule, regulation, reimbursement, for your specific zip code for any CPT code. So this is set to, I was just doing something with an individual in Florida. So this is set to a Florida zip code. And we're going to go ahead and we're going to take a look at some new OCT policy that they have going on in Florida. Okay, so I'm going to just type in my OCT code and I'm going to go ahead and click here. And I'm going to go ahead and take a look at all zip code specific rules. Okay, so I can look here and see diagnoses, right? I can see a national list of diagnoses, 2,300, or I can look for a zip code specific list for this particular practice in Florida, and it's 1,129. So we can find that stuff out very, very easily. If I want to go here and see what the rules are, you'll see here that it'll take me directly to the active rule. And you can see that this rule, the latest rendition of this rule was February 14th of 2017, okay? And I can click on here and I can actually see what the actual rule itself is, okay? So we're gonna look at the actual rule, updated February 14th, 2017, and I'm gonna go here and look at indications of coverage and medical necessity. So this will tell me what I can do and how I have to do it if this was the rule in my zip code. So you'll notice that I'll go through and it'll talk about posterior segment OCT, all of that sort of thing. It talks about, limitations, and then it also will go here and it'll talk about anterior segment. Now I want you to look at anterior segment. Anterior segment SCOTI will be considered medically reasonable and necessary for evaluation of specified forms of glaucoma and disorders of the cornea, iris, and ciliary body. Okay, that's the rule that's in place as of today. Let's go ahead and look what the proposed rule is, 92133. Okay, and I'm going to hit go. And it's now going to bring up two different policies, and you can see here it has a DL instead of an L, and we're going to look at what the new draft policy is coming forward. And we're going to look at that same thing for anterior segment OCT here, so that way you can understand what that rule is going to show us. Sorry for the slow internet.
Dr. Rumpakis, I have two questions that have just come up.
Yes.
So the first one is conditions that may or may not change but are likely to stay stable, such as retinal scars, WWOP, or retinal lattice degeneration. Can we bill for photos on a yearly basis to monitor them? We would want to know if a change has occurred and if the retina is intact each year.
So the answer to that question is no. You cannot order a photo on an annual basis until you've examined the patient and you either suspect change or you note change in the lesion or the area of the retina that you're looking at. So you cannot do a photo to examine the lesion. You have to examine the lesion, then determine that documenting it photographically is medically necessary for you to do.
Okay, and then the second question is, we are thinking of performing fundus photos on every patient as part of the workup prior to seeing the doctor. Would we need to charge every patient separately for this procedure? If we then did a fundus examination and medical diagnosis was discovered, can we bill their medical insurance? So
no and no and no on all three of those. So you would never be performing fundus photography on all of your patients. You can certainly do a screening retinal image, which I will get to in just a moment in the next slide or two. And I'll show you how to code for a screening retinal image, but not a fundus photograph. Those are two separate and distinct things. And so you can never bill just because you found something. Remember, you have to find something first, then order the test, then perform the test. Okay, so you can't use your photos on everybody as part of your examination. Okay, that just doesn't, you can do a screening procedure on everybody, not a problem at all. Let me go back to the draft policy just so you can see how these rules change. So you remember in the existing policy, it said no problem with anterior segment OCT. Please note in the draft policy, what does it say? It says anterior segment OCT with interpretation report, unilateral or bilateral, is considered experimental or investigational as the available published clinical evidence does not support any clinical value. Therefore, procedure 92132 is non-covered and will be denied as not reasonable and necessary. So the reason that I created CodeSafe Plus, frankly, was to ensure that everybody had current rules right at their fingertips rather than relying on what they think the rule used to be, or what was it yesterday versus what is it tomorrow? Because a lot of people make these assumptions, and assumptions are what actually get us into trouble. So now let's address that question, Amy, just a little bit more in detail, okay? So if I'm doing a screening procedure, okay, or what we would call routine, something that did not have any medical necessity associated with it, any screening test is going to be used the code S as in Sam 9986. That code, which is a level 2 HCPCS code, has a definition of not medically necessary service. All right? That means that if it's performed, it's paid for by the patient, and it's never billed to an insurance carrier, and it always happens before the patient sees the doctor. Those are the 3 predicates that have to be in place in order for a screening procedure to be done. Patient pays for it 100% of the time. Never billed to an insurance carrier, no matter what you find, because there is no necessity established, right? And number 3, it should be done prior to the patient ever seeing the physician. Use the code S9986. So the prototypical example that we use for this is like a eye wellness by OptiView for a screening OCT, or an Optos versus an Optimap versus an Optimap Plus, right, which is a fundus photograph. So remember that routine testing is never billable to an insurance carrier, right? Never, because it's has no medical necessity associated with it. When we're ordering a test, right, it means I've examined the patient, I have now established the need for the test, and now I can perform the test and interpret the test. Okay, so that's why we covered medical necessity at the very start today. So remember, based upon medical necessity, you can certainly bill it with an office visit, be aware of specific code requirements and definitions, and remember that generally everything requires an interpretation and report. So let me ask the audience a question here. So as an example, I want to do a fundus photograph on an individual that has a choroidal nevus in the right eye. How do I code the fundus photography in that particular case? Now, I know that not everybody can answer, so I want you to think of that setup. I've got a choroidal nevus in the right eye. I have a normal left eye. I want to do fundus photography on the choroidal nevus. Okay? So I have to understand the definition of fundus photography. So it's an active code by Medicare. It's bilateral by definition. So if I just submit the code 92250 in and of itself, that is telling the insurance carrier that I performed fundus photography on both eyes. Yet, my chart notes would not support taking a fundus photograph of the left eye, would it? Because there was no medical necessity to take a picture of the left eye. So I have to now reduce the level of the fundus photograph that I did. And you can see on the bottom, for unilateral use, the base code 92250, modifier 52 tells the insurance carrier, I am reducing the fundus photograph definition from its normal definition to something else. And then I'm going to put an RT in this clinical case I gave you today, or the example, to demonstrate that I'm doing it on just the right eye. So again, if I can't demonstrate need for taking a picture in both eyes, then I'm obligated to only take a picture in one eye, and also, guess what? Cut my fee in half, because I'm only performing 50% of the service that the reimbursement is attached to. So very important things to understand, right? And be sure to make sure that the laterality of the procedure matches the laterality of the ICD-10 diagnosis that you are using, right? So if I was to look at, if I go here and I want to look up the ICD-10 code for choroidal nevus, right? I'm going to go, oh, sorry. So benign neoplasm of the right choroid. So my diagnosis would be D3131, right? And so that 1 in the 5th position there would match up with the RT that I would have on the fundus photograph. That's why I said earlier, audits are increasing and the specificity of the ICD-10 codes are really making it easy for insurers to catch us on these mismatches. So if I had a unilateral diagnosis but a bilateral procedure that I was billing for, be guaranteed that is a flag to the insurance carrier, okay? And they're going to catch you on that and they're going to ask for their money back. So now we want to do an order. What do we have to do to write an order correctly? So here's 3 different examples, okay? Number 1, number 2, number 3. Order fundus photo secondary to change in appearance of optic nerve. Good or bad? Order fundus photograph OU secondary to appearance of background diabetic retinopathy OU noted today. Good or bad? Order fundus photograph due to diabetes. Well, really, the best one here is number 2. Why? It specifies what am I going to do. I'm going to order this test on both eyes secondary to a particular condition on both eyes noted today. So again, it's telling the record what I want to do and most importantly, why I need to do it. Okay? Now remember, in many cases, you may have situations where the patient may be fiscally responsible for the test. Maybe you needed to do a 3rd OCT on somebody in a given year, and the insurance carrier only allows 2 OCTs per year. So how do you do that? Well, you use something called an ABN or an Advanced Beneficiary Notice, right? So an Advanced Beneficiary Notice is pretty straightforward. Remember that it's only for Medicare Part B. And you can use it for some commercial insurance carriers as well, although you'll need to adapt the form for those purposes. Never use an ABN for Medicare Part C. Any Medicare Advantage plan has its own version of an ABN, and you have to use each carrier's own version of their notice of member responsibility, okay, not an ABN. So what does an ABN look like? Hold on a sec. Sorry about that. Let's see if now I can't open up that. I apologize. My link is not working. An ABN, remember, is an advanced informed consent that gives the patient the option to do the test or not do the test, fully knowing that it may not be paid for by the insurance carrier. You are obligated to write down exactly why you think this claim is going to be denied. You can't just use an ABN on a blanket basis. You can't have every patient sign one just because. It has to be very specific for the test that you want to do on the date of service that you want to do it. All right? And the patient needs to sign it, and then the ABN gets scanned into their electronic medical record. All right? When you're doing that, you need to tell the insurance carrier that you've done your job in explaining this to the patient. So how do you do that? You put a modifier GA on that code. So for example, if I was doing an OCT of the optic nerve for a 3rd time in a given year, and the insurance carrier only allowed 2 OCTs per year, I would need to tell the patient, I need to order, and I would like to do another OCT because there's some changes. The reason that it may get denied is I'm exceeding carrier annual limits. Your expected charge on this is going to be $105 as an example. And then you have 3 choices. I want you to do it, right? And bill the carrier. I want you to do it, but don't bill the insurance carrier. And then number 3, don't do it. The patient has to sign that, and that has to be in the file before you do anything with the patient. You cannot do these afterwards, okay? You cannot do them after the patient leaves or after the test has been done. So that means docs or staff, whoever's responsible for communicating with the patient, you have the responsibility of doing that. Amy, I can see there's another question that came through.
Yep. So it looks like you answered that first one. The second one that came in is when you are monitoring AMD and other retinal dystrophies for progression, often you find changes in the FAF, not on the photos. Can you do the photo and FAF even though the ophthalmoscopy showed no change? We use the photo as a screening and call the service medical photos when FAF are done as well. Is that kosher?
Oh, that's so let me start off by explaining a rule from the CPT from 2 years ago, actually almost 3, December of 2014, 2 years ago, 2015, the CPT came out and said autofluorescence is the same as a fundus photograph. So you have to follow the rules for 92250 in every respect. And so you can't, perform 2 photos in the same day. If you can't call one a screening and one not, it just wouldn't be appropriate. You're intentionally trying to circumvent the rules in doing things. If you feel like you need to order a photo because you suspect change or there's been a change in the patient complaint and you want to order FAF, then by all means go ahead and order it. But you can't do both a color photo, FAF, all those things on the same day and bill for them in different by using different codes. Okay, so it's really important to understand that rule with FAF. So it's really important, as we talked about, charting and how you do it is really, the critical thing in protecting yourself. So interpretation and report by the physician is an integral part of the special ophthalmic service where it's indicated. All right. Technical procedures, right, are part of the service but should not be taken as the service itself. So remember, if you don't finish the interpretation and report, you never completed the test, and the test is never billable. Okay, you cannot break it up just because you only did the technical portion. That is not how they read the rules when you are actually the one performing the test. If you forget the interpretation and report, the entire test is discounted. The interpretation and report should contain many different items, all right? Now, the important ones are starred here. So please understand that no matter what your format is in your EHR or anything like that, you need to have a statement of the reliability of the test that was done, right? So for example, obviously a visual field or an OCT has a reliability statistic that's associated with it. But for an image or a fundus photograph, you should make a statement like area of concern, well-centered, and of sufficient resolution for clinical decision making. That would be a statement of reliability, right? Of adequate resolution, well-centered, okay? Let me give you an example. I just completed an audit on a practice where fundus photographs were being billed for many peripheral dystrophies of the retina. And the photograph that was in the medical record was a photograph of the central 45 degrees of the posterior pole. The pathology that they were billing for was never even in the photograph, okay? So they failed the fundamental rules on what was being done. So it's really important to understand that you have to make sure that the test is very reliable. Give me just 1 sec. I'll be right back. All right. The second thing is that the test results are very important for you to note as well. So if it's the initial test, obviously you want to interpret the results. If it's a sequential test, not only do you want to interpret the results, but you have to give a statement of comparative findings to previously performed tests as well. And then the most important part is, how did this test add to the clinical care profile for this particular patient? Based upon today's results, condition appears stable, patient to RTC, whenever. Significant change noted in OCT, patient to, change medication, whatever it may be. You really have to show what came into play. How did this test add to the care profile for that individual patient? Any other questions, Amy?
So there is one here that I'll read through the second one. I think you just answered it, but I'll read through it anyway. The first one is, so for a Nevis in the right eye, CPT 92252 with a modifier RT, and the diagnosis code is D31.31.
So it should have been 92250-52-RT.
Okay. And then the second question that came through, it sounds like you might have just answered it. If a patient is coming in for just testing, such as an OCT, after medical necessity is established and you are reviewing the test only, what type of office visit code is usually used? And also, does anything in the body of the exam need to be charted?
So explaining the test results to the patient is not an office visit. You cannot bill extra for that. Explaining the test results to the patient is part of the reimbursement for the test itself. Okay, that is your interpretation and report, and you're just explaining to the patient how that's being done. There's no office visit or additional billing for that particular type of service. If you need to bring the patient back for a physical exam for some reason, then of course you can bill for that, but not for just the review of the test. I don't know if that answered the person's question or not, but so I also want to talk about clinical lab testing because that's becoming a little bit more prominent as well. So when we talk about clinical lab testing, remember these clinical lab tests are covered under a different set of rules and regs called CLIA, Clinical Lab Improvement Amendments. There are specific rules passed by Congress that establish quality standards for doing clinical lab tests actually in your office itself. Okay? So for example, we have Tier Lab 83861. Remember that you have to use a modifier on it, and the modifier is QW that indicates to the insurance carrier that this test has received its CLIA waiver from the federal government, and you're performing it in each eye independently if you're going to be doing it, okay? One of the most important things, though, if you're going to do a clinical lab test in your practice, you have to register with Medicare, and you actually have to be a clinical lab director, and your office needs to be designated as a clinical lab. It's not very expensive, about $300 for a 5-year license to be able to do these clinical lab tests, but they're becoming much more prominent in optometric practice. They also require you to interpret the test, okay, as well. So you have to establish medical necessity, you have to order and perform the test, and you have to interpret the test, just like any other special ophthalmic procedure test. The second one is obviously the Adeno Plus for Adenovirus. Again, 87809, it's a unilateral test, just like they all are, pays about $16.44 per eye to do it. And then Inflamadry is probably the newest one in our practices, checking for MMP9, the inflammatory markers, 83516-QW-RT or LT, and it pays about $15.82 per test. Okay. In the last couple of things, I want to talk about what's going on and why these are such important issues today. So a couple of years ago, we got some comparative billing reports that came out in October of 2015, where Medicare in the nicest way said, hey, we're beginning to look at the frequency of what everybody's doing. We just want to let you know that we're paying attention. So a lot of people now are starting to understand that computer analysis of your claims and the costs that it's coming to healthcare are impacting healthcare significantly. And I have to say, optometrists test at a very, very high level. So here's a website, ProPublica.org. It's a public website. I'm going to go to it right now so that way you can see what that looks like, okay? Because what I'd like you to do is I'd like you to see how easy it is for us to look at statistics on things. So here's ProPublica. I'm going to click on the Data tab right here at the top. I'm going to click on Data, and then in the left-hand column, I'm going to look here, and it says Examining Medicare. So when I click on Examining Medicare, the very first thing that pops up is something called Treatment Tracker. So I'm going to click on Treatment Tracker, and you're going to see here in just a moment that it's going to bring up and it's going to show us frequency of office visits by different specialty areas, okay? So you'll start to understand that when we start to look here and you start to see the amounts of services that are done by various specialties, we can actually pick out optometry and ophthalmology and all of that sort of thing, and you can actually see what your frequency of office visits should be. Here's ophthalmology, right? 52% were a level 3, 32% were a level 4, 12% were a level 2. If I go down to optometrists, if I can find optometrist right here, you'll see that 16% were level 2, 53 were level 3, 30% were level 4. So we're kind of in the ballpark, right, of what we're doing. But more importantly, you can look yourself up. Now, I'm not going to look up any specific provider, although I could look up any provider in the United States. I'm just going to go to the states. And let's just go to the state of Oregon, since that's where I live. And what I'm going to do is go ahead and take a look now of all the practitioners in Oregon, and I want to see what their profiles are. And it'll tell me specifically provider by provider who's actually doing the most procedures and what they're doing and why they're doing it and that sort of thing. Now, here we go. So I'm going to go scroll down here and I'm going to look at optometrist. And once I click on optometrist, you're going to see, okay, here's the top providers, right? And it says that this is ranked number 1 of 361, 9 out of 361, 1 out of 361, bills $366 per patient on average, whereas the average in the state is $113, does 8 services per patient versus a statewide average of 2. Okay, well, I can also just click on that, right? And I can go on down and I can say, wow, what does this practitioner actually do? I can actually look here and 553 patients, 4,500 services, right? 202,000 from Medicare, and I can see every single test that this person does. Wow, extended ophthalmoscopy, right? Number 1 procedure, 1,106 times on 359 patients, $55,000, right? E&M codes, retinal photographs, and the list goes on and on and on, and I can see what they do. So it would be very good for all of you to go ahead and look at your own name, look yourself up to see what kind of data people have on you. Now, of course, the final set of rules that I want to talk about are what we call the Cci Edits. And it always comes under the, John, I just want to do all these things. Why can't I do them when I want and how I want? Well, there's this national set of rules that are developed by the CPT, national and local policies, national society guidelines, and the standard of medical and surgical practices, okay? Now, there's 2 types of codes, right? Column 1 and column 2, and mutually exclusive. So a column 1 and column 2 would mean that the column 1 code is a more comprehensive code, and the column 2 code is a component of the more comprehensive if it's done on the same day. So here's some examples here. The 92083 visual field on the same day as a 99211. A mutually exclusive is a test that's generally not performed by a physician on the same patient encounter. So I couldn't do an intermediate and a comprehensive on the same day. I couldn't dilate the puncta and then occlude the puncta on the same day. I can't do a retinal, an OCT and a retinal photograph on the same day, okay? So we've got these rules that talk about what they are. Now, we can use certain modifiers, and I'm going to go into those in a second, but I want to show you first how we handle that in CodeSafe Plus. So I'm just going to go down here to something called Code Screen, and let's say a patient was coming in for a glaucoma workup, and I said, okay, I want to do a 99212, I want to do a fundus photograph, I want to do an OCT of the optic nerve, I want to do pachymetry, I want to do gonioscopy, I also want to do visual fields, and I also want to do anterior segment OCT because somebody told me I could somewhere, right? Now I can hit just one button and our system will tell you instantly which tests are allowed on the same day and which aren't. So an office visit, like I said earlier when I answered that question, can I do an office visit on the same day as special ophthalmic procedures? Every single one is allowed. Obviously, I've got a conflict between 92250 and 92133. I've got a conflict between 92133 and 92132. Now, obviously, we can find out more information by clicking on these things, but just at a glance now, you can see exactly what you can and cannot do on the same day. So what happens if you want to use a modifier? There are certain modifiers that you can use that will allow you to perform these tests on the same day. However, remember that the number 3 reason for triggering an audit is using a modifier inappropriately. So you have to understand the definition of these modifiers. Modifier 59 is one of the most misused modifiers with performing special ophthalmic procedures, okay? So remember that it's a very specific definition. So it's not appropriate to just do it unless you meet the definition. Remember, it's also a modifier of last resort, okay? So that means you've exhausted every other modifier. Now, in January of 2016, the X modifiers also came out. And so out of all of the X modifiers, which there's 4, XE, XP, XS, and XU, it's important that you understand what they are. Typically, XU is going to be the modifier that you're going to use to replace modifier 59, okay, if you're doing these tests together. Now, there are some circumstances where you're allowed to break the rules. So rather than taking my word for it, let me show you the exact publication. This comes directly from CMS. I wanted to make sure you understood I am using the 2017 guidelines, and it is the final document. And I'm going to go right here to doing fundus photography and OCT on the same day. So you'll see right here it says fundus photography and scanning laser are generally mutually exclusive of one another, that a provider would use only one technique or the other to evaluate fundus disease. However, there are a limited number of clinical conditions where both techniques are medically reasonable and necessary on the ipsilateral eye. In these situations, both CPT codes may be reported by appending modifier 59 to the CPT code 92250. So, the question that comes into play is, what are the ones that are medically reasonable and necessary? Okay, so you have to demonstrate that in your medical record that the patient was going to be losing sight, or it was imperative that it be performed, that both of them be performed on the same date of service. So in other words, you're telling the insurance carrier, listen, I'm breaking the rules because I have a clinical condition that dictates that the rules must be broken, okay? Not because it's convenient for you or for the patient, but because there's a clinical situation that demands that it be done on the same date of service. If that's not in the medical record and you're using modifier 59, trust me, that's a big flag that puts you and your practice at risk, okay? So remember, we talked about CodeSafe Plus. I demonstrated the Cci Edits in there already to show you how to look at them. So with that, we're just at the top of the hour. I always like to try to start on time and end on time for you guys, but I'll check with Amy one more time to see if there are any other tests or any other questions, that came in.
There are a few questions here. Would you like me to read through the questions first, or do you want all of them, or would you like me to read through them individually?
Let's just take them one by one.
Okay. So this one says, slightly off topic, but could you briefly describe the appropriate times to use 92014 versus 92012? What are the differences?
So that one, I will ask, I gave my email address earlier. It's john@prmi.com. Just email me that question, and you and I can have an offline discussion about it, since it's not pertinent to tonight's presentation.
Okay. The next one is, how would you appropriately bill for establishing baseline data for a glaucoma suspect? Standard of care still includes stereo photos. How can you incorporate photos into a patient's care plan and receive reimbursement without scheduling photos ahead of time? To a further point, when a patient is identified as a glaucoma suspect on a contracted comprehensive exam, date paid by a vision plan, what is the best and most appropriate way to establish baseline data for that patient?
So the question that I would ask back is, what was the clinical finding that established them as a glaucoma suspect? And remember, glaucoma suspect is no longer an ICD-10 code. So you have to now tell me exactly what kind of glaucoma suspect they are. Was it a borderline open angle, low risk, borderline open angle, high risk, closed angle, low risk, high risk? So what was the clinical finding that established them as a glaucoma suspect? Was it a thinning of the neural rim tissue? Was it, I don't know, was it a visual field defect that happened in their screening visual field? Whatever it may be would help you to establish those things. Once you've established that they are at risk, then you can order your baseline examination of the retina, the optic nerve, and the appropriate structures based upon what your tentative diagnosis is. So if that answer didn't hit all the buttons that you were looking for, again, please email me and I'll be happy to answer that question in more detail.
Okay. Is there a way to bill photos as screenings and another for medical coding?
Yes, we covered that earlier. If you're billing a photo for a screening, you use the code S9986. It's a not medically necessary service. It's paid directly by the patient 100% of the time and is never billed to the insurance carrier, even if pathology is found. If you need to then order a second photo or a fundus photo, that can also be performed on the same date of service, but remember you have to now do a second type of photo. You can't just go back and repeat the same photo. Your second photo has to provide, by definition, additional information that was not available in your screening photo. Okay? Because if your screening photo provided all of the information, then what's the medical necessity to take another one? So you certainly can do it, but you have to have different settings on your camera or a different type of camera altogether that provides you additional information that was not available in your screening photo.
Okay, if you bill a test and it comes back denied, are you allowed to resubmit with a different diagnosis?
I'm assuming that that question is only meaning that the diagnosis is something that the patient has. I would hate to think that anybody on this call would be manipulating diagnoses just to get paid. So I would tell you that you as a physician need to do your homework first by understanding what diagnoses are covered for every procedure, right? That's why we invented CodeSafe Plus, so I can tell you what diagnoses and procedures are correlated before you even order or perform the test, so you can get paid 100% of the time for what you're doing appropriately. If the patient's diagnosis, if your staff didn't map the diagnoses properly on the claim form, then of course the claim can be resubmitted. But if you're just changing the diagnosis to get paid, that is not something that would be looked upon very favorably. If we have just one more question, we'll do that, and then we'll end it for tonight, Amy.
Okay, I'll give you one last one. A patient thinks they have a contact lens stuck in the upper fornix. What CPT code can I use for a visit and lid eversions in just one eye?
So it would be just an office visit, and it would be the office visit that described the services that you provided the most accurately. So it could be a 92002-012, or it could be a lower level 99,000 code for examination of the anterior segment of the eye. There is no code for eversion of the lids or for removal of a contact lens that's stuck up underneath there. So that's not considered to be a conjunctival foreign body or anything like that.
Okay. So we have a couple other questions here, but what I can do is I can contact these particular doctors, reach out to them, and have them reach back to you if that is. And that doctor just said, thank you for answering that question.
Sure. I think that would be great, Amy. Why don't you just have the additional people who had questions reach back out to me personally, and I'll be happy to answer the questions for them. So I would just like to say a couple of closing statements here. So just remember that our next webinar is going to be on August 16th. We're going to be, I believe the topic matter is going to be covering surgical procedures and how to actually code for surgical procedures and all the rules and regs and proper use of modifiers for those. So I encourage you all to register for that when that comes out and attend that. I'd like to thank Amy for spending her evening marshaling all the questions here and helping me, help you guys for everything. And enjoy the next month of summertime, and I look forward to seeing you soon. Take care. Bye-bye.